Welcome to OncoPharm. I'm your host, John Bazar. I am a professor of pharmacy practice here at the supporting sponsor of OncoPharm, ETSU's Bill Gatton College of Pharmacy. Happy New Year! It's our first episode of 2026. The last time you heard me speak on this feed, I made fun of podcasts who copped out by doing mailback episodes over the holidays, and then I didn't do 2 episodes over the holidays, so who's lazy now? So, we're doing our holiday keep, return, and regift, going through the new drugs approved in 2025, starting back in January with the approval of datopotamab deruxtecan. This is a TROP2 targeting antibody drug conjugate with a topoisomerase 1 payload. Has 2 FDA approvals, one for metastatic breast cancer that's hormone positive and HER2 negative after endocrine therapy and chemo. And that's got some PFS benefit, and so that's like a regular approval. And then we have an approval that's an accelerated approval based on response rate in EGFR mutated non-small cell lung cancer after treatment with a TKI and chemotherapy. This is a keep. I think this is a drug that probably has more potential right now in the lung cancer space than breast cancer, with so many options we have for breast cancer. And the side effect profile, just a couple things to rehash about this drug, because I think it is going to be used for breast cancer too, quite a bit in a lot of places. But we cap the dosing is weight based, and that dose is capped based on a maximum weight of 90 kilograms. So older or larger patients, you have to have that built into your EHR, that cap. There is some pretty severe mucositis with this. The label calls for everyone to hold ice chips or ice water in their mouth for the duration of the infusion, and to use a dexamethasone mouthwash to prevent that. They need to see an ophthalmologist beforehand for pre-treatment evaluation and at the end of treatment, and then they need to use those lubricating eye drops that are preservative-free. Usually these will say like dry eyes on them, but it will also say lubricating on the label. And for those folks who wear contact lenses, not something we routinely ask about, but they need to wear glasses while on this drug. All right, the second approval is treosulfan, which is an alkaline agent that's approved as part of a conditioning regimen prior to allotransplant. Notably, this is one that has some skin disorders, especially if they're on bicarbonate-containing fluids, because of the pH-dependent effects on the drug's stability and metabolism. This one I'm going to regift to some transplant centers. We don't do transplant. I don't have a need for this, but I'm going to give it to somebody else. It does have some better data compared to busulfan in the regulatory studies and the pivotal trials. Without knowing the details, I don't know, for example, if they did PK-based monitoring of their busulfan dosing, and a lot of other nuances can lead into, like overall survival benefits with transplant beyond the condition agent, and a lot of that has to do with, the graft and the donor and immunosuppression and non-relapse mortality and all that kind of stuff. All right, next drug is mirdametinib, which is a MEK1 and 2 inhibitor. Brand name is Gomekli. All right, got MEK in the brand name as a MEK inhibitor. This is approved for pediatric patients at least 2 years of age or older with neurofibromatosis 1 or NF1 that's not resectable. This is a keep. We have other MEK inhibitors, but this is a unique approval. This is, I think, a keep. We don't have a ton of approvals for pediatric patients. Anytime we get those, I think we got to keep them. Next one is vimseltinib, or brand name Ronvimza. And this is a colony-stimulating factor 1 receptor inhibitor, or CSF1 inhibitor. And this is approved in adults with tenosynovial giant cell tumor. It's based on response rate, has more response rate compared to placebo, so we have some placebo-controlled data. Now, this inhibition of CSF1 seems to be a little bit more specific and maybe safer than pexidartinib, which is brand name Turulio. It looks to have maybe some fewer drug-drug interactions. This is one of those drugs, you go back and look at it, and it's a gift you get, and you're like, thanks! What is it? It's too fancy not to keep, so I think we're going to keep this one. Penpulimab, which is a PD-1 targeting monoclonal antibody. It's approved for nasopharyngeal carcinoma, not something we see a ton in the U.S. This is like a nice tie that you get. One, I've already got lots of other ties, got lots of other PD-1 inhibitors. And honestly, I don't wear a lot of ties these days. We don't treat a lot of nasopharyngeal carcinoma, so this is a return. I'm not going to keep this one. The next approval is actually 2 drugs that are co-formulated in a pack, and that is avutometinib and defactinib, and this is the avmapki, like MAP kinase pathway, avmapki and faczinja co-pack. This is a MEK inhibitor, the avutometinib, and then a FAK inhibitor, defactinib. And this is approved for KRAS mutated recurrent low-grade serous ovarian cancer. Now, if you just look at this, you might think one of these is going to be a KRAS inhibitor. No, they're not KRAS inhibitors, but the approval is in this KRAS mutated low-grade serous ovarian cancer space. There are warning precautions in the label for this combination for eye disorders, skin disorders, hepatotoxicity, rhabdomyolysis, and embryo-fetal toxicity. This is one of these things you got, these two drugs together. It's for a very specific indication. It's a target therapy. You hate not to keep it's like a fancy tool that you get a guy, that you've never used before, but you open the gift, like, I know just where to store this in case I need it later on. So that's a keep. The next drug is telisotuzumab vedotin, or Emrelis. This is an antibody-drug conjugate that targets MET. Which is overexpressed on some non-small cell lung cancers, and that is the approval for this space in patients who have metastatic non-small cell lung cancer who've been treated with prior systemic therapy. In this case, that's probably going to be chemo and an immune checkpoint inhibitor. If they have MET overexpression, which is 3+, which is 50% of cells expressing that, so it's a pretty high bar to be MET positive, so to speak. This is a keep. Drug with as many people that have lung cancer, this drug is something that's going to be used. These drugs that target MET, like amivantamab and telisotuzumab, and the TKIs that target MET, there seems to be this on-target hepatotoxicity that decreases synthetic function in the liver, and you see hypoalbuminemia in these patients that can be pretty bad. Albumin's well below 3, as well as some edema that accompanies that. So something to watch supportive care-wise for those patients. The next drug is taletrectinib, Ibtrozi. This is approved for ROS1 positive non-small cell lung cancer. Pretty specific to ROS1, also inhibits TRK A, B, and C as well. It does have activity in some ROS1 mutations, specifically the G2032R mutation. So it has second-line activity. So this is a drug we got to keep. There will be a role for this in our patients. The next approval is a mitomycin intravesicular solution for bladder installation. This is Zeduri, and this is one of these reverse gels that is liquid at when it's cool, and when it comes up to room temperature or body temperature, it becomes a viscous gel, and that helps keep the mitomycin around the bladder, and it's a more local effect. There was a similar mitomycin solution approved a couple of years ago for pileococele administration, so very different. Well, not very different. Still urothelial cells you're targeting, but different parts of the urinary tract for those two indications. So this is one to keep just because it's going to be used a lot, I think, in some of these early bladder cancer patients. The next is linvoseltamab. This is a BCMA CD3 bispecific monoclonal antibody for relapsed refractory multiple myeloma after 4 prior lines of treatment. This is mechanistically similar to, say, teclistamab or elranatamab. Now, we have this data of teclistamab and daratumab in myeloma in the second-line setting now. So we're going to use this in the 5th-line setting. Probably not. I'm going to send linvoseltamab back. Now, maybe down the road we learn that this is really the best bispecific antibody we have targeting BCMA. Don't have that yet, so I'm not going to keep it around. It's going to take up too much space in my closet. It's too expensive just to keep if we're not going to use it. So send this one back. The next drug I'm also going to return, and that's sunvozertinib. This is a tyrosine kinase inhibitor that's approved via accelerated approval for exon 20 insertion mutations in non-small cell lung cancer. Now, the reason I'm returning this, and this has come up in our practice, we have patients who could get this drug and may benefit from this drug, certainly are approved to get this drug, but it's not commercially available yet. I believe this is a Chinese company. I don't know if they have some hesitation to entering the U.S. space. Perhaps they are waiting until the drug gets actually full approval before launching in the U.S., since it's just an accelerated approval, and there is a track record of drugs with an accelerated approval not getting a positive confirmatory phase 3 study and losing that approval. Maybe that's what they're doing. That's just speculation on my part. But in any case, I guess I can return it. We don't have it yet, so how can I return it? But anyway, I'm not going to keep it on hand. Next drug, dordaviprone, or brand name Modaso. Modaso? And this is approved for pediatric patients at least a year older with diffuse midline glioma with an H3 K27M mutation. We're going to keep this. Kids with brain tumors we want to treat, so we're going to keep any option we have for that population. Next drug, zongertinib, brand name Hernexios. Hernexios, that's a pretty nice brand name. This is approved for metastatic non-small cell lung cancer with ERB2, tyrosine kinase domain mutations. ERB2 is the gene that encodes for the HER2 protein. So if they have these actionable tyrosine kinase domain mutations for ERB2, you could use this drug. It has activity in patients after prior treatment, including with antibody drug conjugates. That's an unmet need, so need to keep this drug. The next approval is a gemcitabine intravesicular system. People tend to call this the gemcitabine pretzel. That's kind of what it looks like. It's a device. It's placed in the blood or slowly releases gemcitabine. Not mechanistically, but from a drug delivery device, same rationale, although a very different delivery method of the mitomycin intravesicular solution. We're going to keep this, going to have to put a new wing in the house just to get all these urology patients coming in for this. With a lot of cancer centers, they're done at the urology office versus maybe at where the main pharmacy is making the chemo. All right, the next drug. Probably the drug that's going to make the most money of any of these drugs approved in 2025 is pembrolizumab berahyaluronidase. I don't see any efficacy or safety improvements compared to IV pembrolizumab, but it's going to be quicker, more convenient for patients. So one that we will keep as long as the price is right compared to the IV. The big question is going to be for these antibody and the sub-Q monoclonal antibodies, what happens to the ones that already have an IV bispecific, and how does that affect the cost and the finances of institutions and patients? The 16th drug approved in 2025, imlunestrant, Inluria was the brand name. This is a hormonal drug approved for estrogen receptor positive, HER2 negative, ESR1 mutated breast cancer. We're going to keep this. This is becoming a crowded space, this ESR1 mutated breast cancer population. So nice to have another option in that space. Ziftomenib, or Komzifti, is the second menin inhibitor we have on the market after revumenib. This is approved for relapsed refractory AML with NPM1 mutations. We will keep this. We have cevabertinib, Hernuo, which is a similar approval, basically the same approval as zongertinib for non-small cell lung cancer, non-squamous, that has an ERB2 tyrosine kinase domain mutation. Second line setting, also has activity after exposure to prior HER2 therapies, including antibody drug conjugates. So we'll keep that as well. And then the last approval we have is not necessarily a new drug, but it is similar to the pembro berahyaluronidase approval. This is amivantamab hyaluronidase. This does have some safety improvements with the sub-Q formulation compared to IV amivantamab, in specifically less infusion reactions and less severe infusion reactions. So this is not just a keep, but a keep and replace. Whereas the pembro berahyaluronidase approval, I'm going to keep the pembro berahyaluronidase, and I want to keep IV pembro for amivantamab hyaluronidase, similar to daratumumab hyaluronidase. It's got the same Fast Pro approval, same Fast Pro brand and delivery system. So that's one that I'm going to keep and replace. I'm actually going to keep this and throw out something else. It's like when you get a new shirt, you throw out the old shirt. Get a new blue shirt, throw out the old blue shirt. Get new khakis, throw out the old khakis. That's what we're doing with amivantamab hyaluronidase. All right, that's 2025 drug in review real quick. Not a whole lot of, big picture, very similar to what we have seen in the last several years with regards to drug approval, drug development in oncology. At some point down the road, these monoclonal antibodies are not going to end in mAb. Haven't seen that come through yet in our approvals, but we will. All right, that is what I have for you this week. Thank you so much for listening, and we'll be back next Thursday talking about something else. Until I talk to you again, remember, doses matter. Thank you.